Hello everyone, welcome to the channel. This is your Dr. Snitch, where we simplify complex medical concepts, and today we will dive into the topic of shock, its types, pathophysiology and clinical approach via case explanation straight from the Harrison. Since this is my first video and you all are new here, consider subscribing because every week we will break down essential topics just like this. Let's begin with the clinical case. Now imagine you are a doctor and your duty is in emergency department. Now, a 58-year-old man came to your department with altered mental status, hypotension, decreased urine output, blood pressure is 80/50, respiratory rate is 26 per minute, heart rate is 122 per minute, jugular veins are flat, extremities are cold and clammy. Lab reveals a metabolic acidosis with high lactate, elevated BUN and creatinine. Chest X-ray is normal and ECG shows normal except sinus tachycardia. This is the classical case of shock. I'm sure you all know because of the title and thumbnail, but let me ask you a question. Which type of shock is it? And if you know the answer, then you are just wow. Let me know the answer in comments. And if you don't know, we will now explore this case in detail, and trust me, by the end of video, you will all differentiate the type of shock just by the symptoms. Now, what is shock? This is the standard definition straight away from the Harrison, which includes the fancy words like life-threatening medical emergency, severe impairment of tissue perfusion, cellular injury dysfunction, etc. etc. Now, I made the simplest version of the definition from this and I'll tell you how to remember it. Now use your common sense and see. Shock means our organs are not getting enough blood. Without blood, tissues don't get oxygen. Without oxygen, cells stop working. And if the cells stop working, eventually the organ will fail. It is deadly. If not treated fast, most patients end up in the ICU. Now we will learn about clinical manifestations in depth. I already told you about clinical symptoms before when we discussed the case of the patient. Now we will learn about specific facts along clinical features. For example, we can see hypotension, especially mean arterial pressure below 60. We can see the cold and clammy extremities in patients, but it is because of the vasoconstriction. There is one exception. There is a type of shock which is distributive shock, where we can see the warm extremities instead of cold extremities. In oliguria, we can see less than 20 ml output. And finally, we can see the signs of acute respiratory distress syndrome such as hypoxemia, diffuse infiltrates and non-cardiogenic pulmonary edema. Now, out of these all clinical manifestations, these 5 signs are the most common one, and believe me, you should remember it. Now, shock happens because of the low cardiac output or low vascular resistance or both. There are 4 main types of shock, which includes hypovolemic shock, cardiogenic shock, distributive shock and extracardiac obstructive shock. Let's go through them one by one. First, hypovolemic shock. This is from fluid loss, for example blood loss or plasma loss or both. In causes may include most commonly hemorrhage, then severe vomiting and diarrhea, and excessive usage of diuretics. Then we include pancreatitis and bowel obstruction. But if you ask me the hallmark feature of hypovolemic shock, I would say flat neck veins, because there is not sufficient pressure in veins because patient is continuously losing fluid. Now, hypovolemia triggers neurohumoral responses leading to free water retention and possible hyponatremia. Now second, cardiogenic shock. It occurs because heart fails to pump, or commonly say heart failure. In causes, we can include acute myocardial infarction, dilated cardiomyopathy, and in severe valvular problems like mitral regurgitation and ventricular septal defect. We can also include arrhythmias, and oftenly jugular venous distension is present. And in key features, we can see systolic blood pressure is less than 90, pulmonary capillary wedge pressure or filling pressure is more than 20. We can also see oliguria, vasoconstriction, dull sensorium, and metabolic acidosis. Now, there can be aortic dissection as one of the cause of cardiogenic shock. And aortic dissection and myocardial infarction, their clinical features are almost same. And to differentiate between these two, we can also do transesophageal echocardiography. Early percutaneous intervention and coronary artery bypass graft post myocardial infarction can significantly improve the survival, and we can save lives. Now third, distributive shock. The reason behind this is low vascular tone, often with high cardiac output. Because of increased cardiac output, there is increased blood flow, and as we discussed before about extremities being warm, the reason behind this is pathological vasodilation. The common causes of distribution shock include sepsis, anaphylaxis, neurogenic shock. The endocrine diseases like Addison disease, myxedema, liver failure, pancreatitis, or burn. In this type also, we can see neck veins are usually flat but not common as hypovolemic shock. Fourth, extracardiac obstructive shock. It occurs because something blocks the heart from the filling or emptying, means blocked during the contraction and relaxation of the heart. For example, pericardial tamponade, massive pulmonary embolism, tension pneumothorax. These are the true emergencies. Now, diagnosis, history and examination. Diagnose starts with a good history. We should look for non-cardiac disease, recent infection, drug use such as diuretics, and bleeding sources. After history, we should do examination of patient in two forms. First, physical examination. Second, laboratory diagnosis. In physical examination, if we find jugular venous distension, it is the case of cardiogenic shock. If we find flat veins, it is the hypovolemic or distributive types of shock. If we find pulsus paradoxus, in case of cardiac tamponade, it's obstructive shock. If we find pulse asymmetry, in case of aortic dissection, it is cardiogenic shock. If we find skin findings suggestive of pathogens like Neisseria and Pseudomonas, it is the case of infection leading to septic shock. In laboratory diagnosis, we should do CBC, WBC, electrolytes, coagulation profile, and DIC screen. In case of acidosis, we should do arterial blood gas and lactate level. If sepsis is suspected, we should do blood culture and site-specific culture. We should also check renal function. Now, imaging and monitoring. We can use ECG for arrhythmia and ischemia. We should use chest X-ray for case of pneumothorax or heart failure. We can also do echocardiography in case of cardiac tamponade or ventricular problems or aortic dissection. Central venous pressure and pulmonary capillary wedge pressure can help differentiate types of shock. For example, if PCW level is less than 6, it is the case of hypovolemic or distributive shock. If PCW level is more than 20, it is the case of cardiogenic shock. We should always monitor vitals continuously, like blood pressure, ECG, oxygen saturation, urine output, and mental status. Now, in treatment, first of all, we have to make sure that patient can breathe, so we should give 100% oxygen. If the partial pressure of oxygen is less than 70, then we have to intubate the patient. Also, we can use lung protective ventilation strategies with low tidal volumes. We should always begin fluids by 500 to 1000 ml bolus of saline or ringer lactate. But if patient is anemic, then we should transfuse the blood. In case of hypovolemic hyponatremia, crystalloids are preferred. If fluids don't fix the blood pressure, then we should start giving drugs, for example, vasopressors like norepinephrine for distributive shock, inotropes like dovitamin for cardiogenic shock. Also, we can add drugs like dopamine and phenylephrine if needed. Since we are giving the sympathomimetic drugs, we can add milrinone as non-sympathomimetic for compensatory mechanism. Acidosis means blood pH is less than 7.15. We should identify and treat the underlying cause as soon as possible. In case of sepsis, we can give antibiotics and drainage. In case of cardiogenic shock, we should do revascularization, we can give diuretics and nitrates. In case of hyponatremia, we can give isotonic fluid resuscitation. In case of pulmonary edema, we can give oxygen, diuretics, ACE inhibitors, and morphine. Now, let's learn about hyperkalemia and shock. High potassium can be dangerous. The key treatment, we should give calcium gluconate to stabilize the heart first of all. Second, there is a lot of extracellular potassium, so we should give insulin with glucose and beta-2 agonist to shift potassium intracellularly. Third, we can eliminate potassium using K-oxalate, furosemide or dialysis. And after administration of these, at last, we should watch for the ECG. If told T-wave are normalizing after the treatment, it is working, and if not, then we should give the higher dose of treatment. Now, for prognosis and prevention. If we are comparing severe sepsis and septic shock, mortality is high up to 60% in septic shock. Apache 2 score can help to predict the mortality. For better understanding, see this graph here and try to remember it. Prevention means early infection control, ICU precautions, and early antibiotics for high-risk patients. This is the table of hemodynamic characteristics straight from the Harrison. It is looking a bit confusing, but trust me, it isn't. Now, see, there is 4 parameters for this: central venous pressure, pulmonary capillary wedge pressure, cardiac output, and vascular resistance. Now, we have to remember only 2 parameters out of this. First is cardiac output and second is central venous pressure. Now, only in distributive shock cardiac output is high and other values are opposite to cardiac output. And remember, distributive and cardiogenic shocks are totally opposite types. Got it? Now, obstructive and hypovolemic see central venous pressure along with cardiac output. If both the values are opposite, it is obstructive type, and if both the values are same, then it's hypovolemic. Easy, right? Now, this is the referral case which we studied today. Pause the video and see symptoms again. I give you 5 seconds to answer. And the answer is hypovolemic shock. I'll tell you how. Our first option is distributive shock. Now see, in this patient we are not seeing any kind of signs about clear infection or any kind of history of burns and related to pancreatitis, but we are seeing one specific symptoms about extremities which is called enclemy, and we learned that in distributive type of shock we are seeing warm extremities, so this cannot be distributive shock. Our second option is cardiogenic shock. Now see, in this patient we are not seeing any kind of myocardial infarction history or ischemia history, or we are not seeing any kind of pulse asymmetry for aortic dissection, so this also cannot be a cardiogenic shock. Our third option is obstructive shock. Now we learn and we already know that the reason behind obstructive shock is cardiac tamponade or pulmonary effusion or tension pneumothorax, which is clearly visible on X-ray. And in pressure D3 we are already seeing that X-ray values are normal, so this cannot be obstructive shock. Hence the answer is hypovolemic shock. I'll tell you how. Because we see in the patient there is decreased urine output. This is because of low volume present in the patient, and we are also seeing the jugular veins are flat, and I told you already that there is a hallmark feature of hypovolemic shock which is flat jugular veins, and we are also seeing extremities are cold and clammy. So this is the classical case of hypovolemic shock which we discussed. And that is it. Simple, right? No rocket science. Now, if I add a value to your knowledge, then please like this video and subscribe to this channel. Liking and subscribing in just 2 seconds will make up for all the hard work I put behind this video. This is Dr. Snitch signing off. Keep learning, keep healing, and I'll see you in the next lesson. Thanks for watching.